So we have had a concept that one of the reasons why patients may respond better or worse to immunotherapy is based around this tumor mutation burden, and that it's not just MMR deficient bowel cancers versus the non-MMR deficient. We've seen it already in other tumors, such as in melanoma, such as in lung cancer. And the concept is that whether it's DNA damage, whether it's smoking, carcinogens, or inherently a DNA repair defect, there's a huge amount of genetic mutations that then is a kind of correlate with what we call neoantigens. So these are kind of almost like foreign or rubbish antigens sit on the cell surface. And you would expect the higher the mutation burden, the easier if you can stimulate your own immune system. This is what these checkpoint inhibitors do, to recognize these tumors as foreign, you will get a better response. Yeah, and it generates that better response. In the metastatic setting, because we are giving immunotherapy for advanced stage 4 locally advanced cancers, there were some small papers that showed that the high mutation burden, it was better. In others, it was not the same. And I think it would beg the question that, particularly if we are thinking about using a biomarker in the metastatic setting, if we are moving treatment into the neoadjuvant setting, and all these concerns about whether we're over-treating or under-treating in the neoadjuvant setting, you could just chop these cancers out and then leave them alone. Could we use that as a stratification, more than anything, to whether you should give more or less immunotherapy, and also whether you respond to immunotherapy? So that's kind of a long answer, but then that borne out the concept that, well, okay, so we're going to give lots of people MMR who are MR deficient, MSI-High, which are the current only biomarkers to say you may well respond. We know that if you're not, you won't. But even if you are, we don't really know how precisely you'll respond. So it's really a stratified trial, a small phase 2 trial, just to kind of the concept of, would it shrink the cancers down? Would it be safe? And and you have 2 arms of the study. So that was the kind of idea. And then actually, as you probably see, it's like it was just one part of this kind of translational work, and it was not the be or end all. It was a surrogate marker for would it respond, but we built in all these other things, not just in terms of this commercial test. So it comes down to this Foundation Medicine 1 test, which is well known, FDA approved. We'd use it to get other markers as well. And at that time, we talked to the companies and said, okay, your low is what we call 5 or less mutations per megabase. 6 to 19 was medium, and 20 or more was high. And the reason why I use that assay more than any other assay, because there's lots of other assays, Diana said, it's really well known. A lot of people use it for lots of things. And I thought, if we're going to use this in clinical practice, then use something that everyone kind of understands, at least. Even though we know it is not the best assay ever for everything, it's still something we can understand. So I think the first thing to say that the first thing was that regardless of the TMB rate or highness, it was like we had to kind of decide what was our PAF-CR rate. And before I tell you how I exactly calculated, it was difficult because we had no real gold standard. On one hand, we already had some data coming out from the niche trial, which was Dr. Chalabi's Nivo-Ipi, just combination Nivo-Ipi for 4 weeks, and she showed a pathological complete response rate of 60%. It wasn't stratified to TMB, and also the primary endpoint wasn't that. That was a secondary endpoint. The primary endpoint was safety. And even when you look at the other study by Andrea Sursek, which was 6 months of single-agent dostarlimab for locally advanced MMR deficient rectal cancer, although she had that stunning result, which was published in Journal of Medicine, which showed like no one has relapsed, the initial fill was 25% complete, clinical response. And I suppose we all just weren't sure, because what we know in the metastatic setting, we are seeing from the KEYNOTE-177 trial and now the HAW trial that we're getting durable responses which are lasting out to 5 years of between 35 to maybe 40% of patients. And I suppose you could argue, well, that's where you got the 30%, Dr. Shiu said. Not really, but I suppose that's a starting point. I kind of just said, I think it's reasonable that it would be good to get a path complete response of it in at least a third of the patients. And also because I had the prior knowledge of what other studies were doing, I kind of worked out, well, that's, I think, clinically meaningful. And I think that's the other thing is that what is clinically meaningful? Um, as I said, I could have said at 50%, I would have still exceeded it. I wasn't going to go to 60% or 70% because I think that's difficult. And also from the statistical point of view, it was like it was an academic study. So I had to kind of work out a way where I had enough patients to do the statistical significance for what we thought it was. So that's kind of a long answer. So in the end, 30% kind of felt right, and it felt right for the number of patients I could put in for the funding that I was getting for this kind of investigative study. So that was my set goal. The other thing to say was that the statistical analysis was based completely on this TMB high medium group, not the low group. We already knew from looking at other data that maybe only, I don't know, 10, 20% of the patients might be TMB low. And it wasn't just based on the low. And I think something that had not time to kind of discuss in the discussion even was that it was not just low TMB, it was failure of the assay. Okay. So when we went to the company and said, right, we're going to just take biopsies. Remember, these are just colonic biopsies. And getting DNA extended profiling is quite tricky because in normal practice, when we're doing it for advances, we've got great big chunks of cancer. We've taken the resection, we've taken liver metastases out, lymph nodes, lung metastases. We've got lots of bit of tumor. So the company said there might be a 10 to 50% attrition rate. That means that you won't even get the assay. So you have to understand if you don't know what the TMB high, medium, low is, you have to put them in the what I call the failure of the assay group. And very interesting, we had none. So we had no failure of the assay. So that's partly why when you look at the data, only one patient was TMB low. And interestingly, for me, I didn't really find that surprising. What I found very surprising was there were no TMB mediums because we definitely see TMB mediums in the advanced setting. People who've got TMB of 12, 13, 14, 15, and you do worry that maybe they don't respond so well to immunotherapy. And we really had none. The other thing I would just say is that when you look at the data, the least high was about 21 mutations per base, which is technically high, all the way up to like 82. And at the moment, I think it's because of small numbers, we haven't got any true statistical correlation that that the high are better than the low. And we've all got, well, not all got, there were patients in that waterfall plot who had a TMB of 22 with a path complete response rate. There are people with a TMB of 60 and had a partial response. So I think, again, what I have generally thought is that TMB is a surrogate marker for something which is very interesting, but it's probably something much more complicated beyond mutation burden. And we now know, of course, immunotherapy is very complicated. It is not just about neoantigens and DNA. It's around the tumor microenvironment and all these other things. So that's what also the trial was building into, that there was all this other thing that we would correlate things like liquid biopsies, microbiome, TCR complexity, tumor microenvironment, when integrated it with the response rates as well as this TMB readout. So we were gratified, and I was, to be honest, not surprised because, single agent immunotherapy should not be that toxic. And also we were only giving it for 3 cycles. And that's what we found. So there were a lot of AEs because when we were talking about AEs, that means any adverse event. We went from AEs from the patient's symptoms, from the surgery. We went for the entire trial. So it was not just about safety of immunotherapy. It was safety of giving immunotherapy before an operation and any consequences afterwards. But what we actually basically found out was that there were only 2 patients who had any what we call significant grade toxicity, which is called grade 3 or 4. In fact, there were no grade 4 or 5 toxicities. They just had a bit of fatigue, grade 3 fatigue, a raised ALT, which is a liver enzyme, and also some myalgia, which is kind of aching of the muscles. And none of them were what I call critical, and they all still carried on with immunotherapy and all did it then. And I think that's important because compared to some other studies where you've given combination immunotherapy, there have been toxicities. So not just in the knee study, but there was a Chinese study also presented at ASCO, and there was one person who died from the side effects, which we probably think is from the CTL4. And I think that's the other thing you got to think about. Remember, all of these patients potentially are cured by surgery alone. So if you're going to give a treatment, okay, you've got to make sure it's safe. On the other hand, what I have said, and my other kind of investigators who worked on the study, and also other people on the other side, say, look, when you do, for example, operate on someone, it's a standard of care, resect the tumor, and then you offer them potentially adjuvant chemo, which, we normally quote them a risk that you could die of sepsis, blood clots, heart attack, about 0.5. That's 1 in 200. Yeah, and that's significant. You can die. And I think that's the main thing. Any treatment, has risk. And I think it's a question of balance of risk and how significant the benefit is of that treatment. And what we do think, not just based on this study, but most other neoadjuvant studies, if you achieve a path complete response rate or near complete response, that really does signify that you're probably going to live a longer. That's one thing. The second thing is we were not giving routinely adjuvant immunotherapy or adjuvant chemo. And that really helped the patients. A lot of patients who came and say really like the idea because they heard already chemotherapy is horrible, it makes me sick, tired, infection. And it was great when they said, look, it really shrank down. And now you can just, after your surgery, relax, as in just recover from surgery and not think, oh my God, in 4 or 6 or 8 weeks, I'm going to have to go through 3 months of chemotherapy before even then, I'm not sure it's going to keep the cancer away.